Hi, this is Cameron Dezfulian from Baylor College of Medicine, and today we're going to be talking about Peds Critical Care Medicine procedures. And this lecture is going to be divided into two sessions. The first we're doing now, and then the second will capture the remainder of procedures. On this module, we're going to go over anatomy and assessment. We're going to talk about establishing an airway, vascular access, and finally a section on POCUS, which I think is up and coming in all of critical care and on the boards. So starting with anatomy and assessment, we have a question. You're preparing to intubate a 6-month-old girl. The most likely point to meet airway resistance when passing an endotracheal tube is at the level of the thyroid, cricoid, cuneiform, arytenoid, cartilages, or the vocal cords. And so the right answer there is the cricoid cartilage. And so hopefully everybody throughout their fellowship has been told about how the pediatric airway as opposed to adult one narrows like a funnel. So here you see the adult airway that is looking like a cylinder and pretty much the same size going down, whereas the pediatric one is more like a funnel. And as a result, the cricoid, which is the most caudal of the structures, is where you have narrowing. For a while, that was actually used to kind of support the notion that uncuffed tubes made sense because this, in effect, provided a cuff. I think for the most part in Peds Critical Care, we've gotten away from that because of the reality that if you need high airway pressures, an uncuffed tube is just going to lead to a prohibitive leak. And so we are using cuffed tubes, but still, as you're inserting your tube, this is where you're likely to meet resistance. And, you know, although this is not something that I think is going to be testable on the boards, I think it's an important point. If you do try to intubate somebody and you meet resistance here and you can't pass a tube, first of all, sometimes removing the stylet might help you pass it. And the second thing is, even if you can't do that, you can leave your tube in this position, bag the child up, oxygenate them if you really didn't have a good airway to start with, and then using that as your airway, you pull it out and put a new half-size down tube in that will pass. And I've gotten in that situation a couple times, and if any of you get into it, hopefully it'll save you from having a no airway situation, which is pretty scary. So there are a lot of changes in anatomy that happen with age. Compared to adults, kids have a much bigger head and occiput, and as a result of that, the sniffing position that we always want to put them in is different, and the need for towel versus head rolls is different as they progress in ages. So mostly with kids, we often need a towel roll underneath their shoulders to kind of help boost them up, as opposed to in some adults, we actually need to boost their head up because their chests are so big relative, using some placement of towels and stuff underneath their head. In addition, the oral cavity is relatively small, which means the tongue's relatively large, and the airway is a little bit more anterior. All of that makes it a little bit tougher to get a good view. The other thing I'll throw in here that isn't included is that the tonsils, particularly in your school-age kids and a little bit preschool age, can be particularly large, right? So all of those things may make your view difficult, and you just need to be aware of it as you're approaching a pediatric airway. So when you go to do an assessment, when you have an opportunity to do an assessment before intubating, you want to note things like the tongue size, the tonsil size, whether they have any atlanto-occipital issues, so Down syndrome, for example, being a prominent or common one that has instability. You want to check out what the distance is basically from the mandible down to their cricoid cartilage, hyoid cartilage, and so that's used with putting your fingers just at the level of their jaw and measuring that out. And ultimately, you want to just judge whether or not you're going to be able to get the view you're getting. Some obvious things that are going to restrict you as a child who's in a halo or in a collar, and certainly kids who have things like Pierre-Robin syndrome right off the bat, are going to be difficult airways. In addition to that, your assessment, just when you're about to do deep sedation or anesthesia, should be this ample algorithm where you take in their allergies, their meds, their past medical history, when was their last meal. Obviously in elective procedures, you'd like to have them NPO for a sufficient amount of time that you're not risking aspiration, and then any other circumstances that are going on. So things that are associated with difficult airway we kind of covered: limited opening of the mouth, macroglossia, limited neck and spine mobility, or being in a structure like a collar or a halo. mandibular hypoplasia, which then makes the jaw much smaller relative to the tongue, an arched palate, a variety of craniofacial abnormalities that we see in syndromic kids. Obesity just overall can make it harder to get the lift that you want, particularly if you're dealing with adolescents. You may have to use actually a fair amount of strength. And in those situations, if you have an obese adolescent that you're intubating, we had a bunch of these during COVID, you may want to angle the bed upward more like 30 degrees, 45 degrees, and be standing quite high, probably either on the bed or on a bunch of stools, to be able to get a lot of their weight down and off the chest so that you can get the view that you need. Mucopolysaccharidosis and other infiltrative disease can infiltrate also within the airway and make the view very difficult. So here I have a list of just a variety of syndromes and some of the airway implications. I'm not going to go over these one by one. We've touched on a few of these syndromes. I think the more common ones that I've encountered in my practice are Downs and Pierre-Robin. And so just be aware that with these syndromes, you have a potential for a difficult airway. And all that means is that as you're approaching that airway, you want to plan out what your backup is and be ready for a difficult airway situation. In some situations, you want to have ENT or anesthesia doing this, potentially fiber optically or ready to trach.